Hey guys, Woodruff here. I was thinking about shock the other day because who isn't? And came up with this simple shock case study. I think that the hardest part about sometimes learning about hemodynamics and shock is putting it into practice. And so a lot of times it seems very like abstract or strange when you think about these things until you start to really put it into like, well, when am I going to see this? What am I going to need to do as the nurse for a patient that has like altered hemodynamics and shock? So hopefully this is helpful. And I made this like a week ago, so hopefully not too many errors. And I know what I was intending to say previously. So let's jump in. So let's get a little bit of background. A little background on our patient. Our patient is a 77-year-old female. They have a history of diabetes, hypertension. They've had a heart attack in the past, CAD, coronary artery disease, and diabetes. So already, one thing you want to think about when you're on a test or trying to figure out if you're in real life, trying to figure out what kind of shock your patient has, you always want to consider what's their history? Because a lot of times history can put someone at risk for something. So just based on this history, a lot of you are probably thinking, a lot of cardiac stuff. I bet this is cardiogenic shock. We can't just base it on that. It depends on, this person has a lot of risk factors for other types of shock too. It really depends on her story. Because we can look at hemodynamics and have a good idea of what kind of shock someone's in, but their story or other ancillary or labs, history, stuff like that, recent events is going to tell us a lot. So they're having lower abdominal pain. So that's not too consistent with cardiogenic, but we'll see. They're confused and only oriented times one, which means, and it doesn't say what, but maybe they're only oriented to who they are. So how will we differentiate what kind of shock she is in? What risk factors does she have for each? So there's a variety of types of shock. The main ones that are taught in nursing school is we talk a lot about we talk a lot about cardiogenic, we talk about hypovolemic shock, and then septic shock. There are obviously other types like anaphylactic shock, neurogenic shock. Those are usually covered at different times in nursing school. But, so far this lady, she's not showing any signs of having anaphylaxis, like an airway issue. And nothing about a recent spinal cord injury. So neurogenic shock doesn't seem as likely. Just with what she has going on. And so to differentiate, you want to think about what their story might sound like. And so for example, with cardiogenic, what would be commonly in their story is maybe a cardiac history, but usually they're going to have symptoms maybe like chest pain. They could have fluid overload, difficulty breathing. It's a lot of heart and lung stuff. I'm not saying always, but 9 times out of 10, because usually all the causes of cardiogenic shock are going to be something involving the heart, and or sometimes that there's symptoms that then show up in the lungs as a result of the heart not working really well. Because really, if you think about cardiogenic shock, it's just like heart failure. And so keeping it simple, when you think about cardiogenic shock, it's someone who has some heart pumping issue. And maybe they have a heart pumping issue because they had a heart attack. Maybe they have a heart pumping issue because they have really bad, other vascular disease. Maybe they have a heart pumping issue because they already have heart failure and it's getting worse, or maybe they got an infection or inflammation of their heart. There's a lot of variety of things that could be causing it, but it's a heart pumping problem. And based on her symptoms so far, I'm not seeing anything cardiac related. Now, older people can respond differently, but we'll see. Then, like I mentioned, there is hypovolemic shock. So with hypovolemic shock, we're looking at someone who's had a acute loss of fluid or blood. Usually these are people that have undergone trauma or are bleeding somewhere. It also can be people that are profoundly dehydrated. So it's possible here, that it's possible that she could have something going on with that. Or it's someone who they have fluid, but it's in the wrong place. So people that are third spacing, like liver patients, or people that have undergone a burn, things like that. So far, and then there's septic, and with septic shock, there's usually obviously some sort of infection going on. And then they have it's like a vasodilation type of shock. So they can, they can have some perfusion, some peripheral perfusion issues. But usually like the things that really, that's like everybody. So I don't want to say that, but when you think septic shock, you should think someone with an infection, think someone who's showing signs of an infection. You know, the most common places we get infections, pneumonia, urinary tract infection. They can also have wound infections, things like that. So you'd be looking for things in the story about signs of infection. Now, don't get too much of a trigger finger where the second you see like something I'm bringing up, you're like, oh my God, it has to be this type of shock. Read the whole story, read all the hemodynamics, all the labs, vitals, whatever data they give you to make sure that you know what's going on. Because sometimes some shocks can look a little different and there's just little things that make them look different, but we'll get more into that. So far we have this lady, lower abdominal pain, confused, only oriented ×1, coming in. So it says what further assessments need to be done and what's priority. So with this patient, you know, obviously we want to do a full head to toe, but what's going to be most important? How are we going to get to the bottom of the problem? Well, I think first, you know, I want to get some vital signs, see, is she actually in shock? You know, how's her perfusion status? How are her hemodynamics? Based on her lower abdominal pain, a lot of times that's how older women present with a urinary tract infection. So maybe some urine studies or seeing if there's anything abnormal in her urine. I'd want to do more of a focused assessment for her mental status and her abdominal pain, kind of looking at what's going on there. And then I want to look at her perfusion too, because, you know, as a whole, sometimes patients can have changes to their peripheral perfusion as like an early sign that they're starting to go into shock. So like that's like capillary refill, distal pulses, color, temperature, think like neurovascular. And then after that, of course, you know, we want to listen to heart, lungs, all the stuff, but we always want to hone in and try to get to the answers for maybe what's going on with this patient as soon as we can. So like I mentioned, vital signs, and you know, with vital signs, you want to think about what are you going to be paying attention to. You want to look at the blood pressure and calculate a MAP. You know, a lot of times if you're in nursing school, they're probably still going to ask you to calculate a MAP, like do the math, so know those equations. If you're in practice, then I would, you know, recommend just knowing in general, we like a MAP greater than 65 for normal vitals. We want to check that heart rate because that heart rate tells us a lot. And in every type of shock that we talk about, except for neurogenic, the heart rate's going to be elevated. I'm trying to put my finger there. Elevated. And so you're gonna look for an elevated heart rate, and it's elevated for different reasons. Like in cardiogenic, it's elevated because the body's compensating because the heart's not pumping well. And hypovolemic, it's elevated because there's not a lot of volume. And so there's also the compensation, but it's because of loss of fluid. And then in septic shock, it's elevated because there's a decreased, well, I mean, really all of them, if you keep it simple, it's elevated because there's decreased cardiac output, but it's because there's different reasons. There's decreased cardiac output in septic shock because we're really vasodilated. Yeah, that's what you want to kind of look for, that heart rate. You'd expect an elevated heart rate. A lot of times, especially if this is septic or hypovolemic and there's bleeding, then we would want to look for an elevated respiratory rate and see if that's increasing, because that's kind of an early compensation your body does when things aren't going well. And then, of course, if we're concerned about septic shock, we want to check a temperature. So yes, we want to know if they have a fever, what's going on with that. And then get an oxygen saturation. And we definitely want to make sure that this patient gets the oxygen that they need if they're in some sort of shock process, they're already struggling to get perfusion, we don't want to make it any harder on them. I mentioned the urinary assessment. So this would be like getting a urinalysis and seeing if there's anything in that. Now, this is a good throwback to med surg. What would you have in a urinalysis for a patient that has an infection? So we'll talk about that soon, but start thinking about what would you find in that. A focused abdominal assessment, because we said lower abdominal pain, but we want to see is there tenderness. We want to make sure their bladder's not distended. And things like that, making sure also that there's no signs of an acute abdomen, like rebound tenderness, stuff like that. Look for signs of poor perfusion. Like I said, think those 7 Ps and 1 C, the neurovascular assessment, and then the remaining parts, the head to toe. So our results are back and the urinalysis is positive for, and this is your little reminder if you don't remember, that if there's, and I guess I'm giving you hint, that there's something not good here. The urinalysis is positive for bacteria, glucose, nitrates, and leukocyte esterase. And so you have to ask yourself, is there supposed to be bacteria in your urine? Not so much. Is there supposed to be glucose? Not really. And this doesn't necessarily mean that they're in DKA or something crazy. Remember, when people are diabetic, that they can lose glucose in their urine. It's usually a sign they have too much in their blood. So, and then keep in mind too, that depending on the type of shock, glucose is, well, in general with shock, the fight or flight hormone is released, which can increase your glucose alone. So the body might be stressed. Or if there is an infection going on, more glucose might be being released in order to fight that infection and help the body. I was like, excuse me. So then there's nitrates. So nitrates are something that are usually positive when, and same with leukocyte esterase when there is a infection. So far we're seeing that there might be some sort of UTI, but we still need more information, excuse me. So we have a blood pressure of 99/60. And if you want to go ahead for practice and calculate that map, go ahead and do it. But we're on the low end of normal, and especially because in older people, we generally consider a blood pressure less than 110 on the low end, because, even though they can, sometimes some people will be like, oh, my blood pressure runs lower. Hey, sorry about that. If it sounds like cut looped, I had to pause it for a second because I was dying, but I'm good now. Anyway, so like I was mentioning, older people, sometimes we have a lower threshold for worry for them. With volume loss. Their heart rate's 115. So like I said, it's kind of expected to be elevated in all types of shock, except for neurogenic, it's going to be elevated. Respiratory rates increasing, which might mean that they're compensating. They're trying to increase their oxygenation and perfusion. Really, respiratory rate's all about ventilation, but they're trying to increase that in order to maybe compensate for an oxygenation problem. Sorry. Anyway. Their oxygen's 93% on 2 liters, which is probably lower than what I want it to be. And then they got this a whopping temperature. So right now, let's see, what type of shock are we suspecting? So right now, based on what we know, it doesn't seem like there's a heart pumping problem. There doesn't seem to be necessarily any blood loss, anything like that. I know I didn't give you all the other findings and stuff. Right now, what kind of shock are we pointing to? We're pointing towards septic shock, if you did not get it already. So let's think about what are some things we're going to do for septic shock. So septic shock is a massive, like pretty much infection comes in, and after infection comes in, then the body responds by opening up all of its doors, aka it's the fancy word for is increasing capillary permeability. And what it means is that the doors open in the blood vessels to allow the things to come help fight infection. But in the meantime, while they're doing that, since those doors are open, fluid leaks out. So you start having this massive vasodilation, and fluid starts going where it's not supposed to go. Blood pressure drops, cardiac output drops, and the body becomes overwhelmed by massive infection, and it's an infection in the bloodstream. What we need, of course, first, their blood pressure's low, and we want to help to dilute. Anytime you have too much of, not anytime, but most of the time when you have too much of something in your bloodstream, you want to decrease it. So we usually like to dilute it. So I'm thinking like fluids. And of course I have a infection issue, so I might have to give something for the infection. We'll probably want to get some other labs, and then checking in on the, like we've sent a urinalysis. It looks like there's infection, but I might need to send some future further cultures, like get a culture to see what's growing and maybe see if there's anything growing in the blood. Those are some of my initial thoughts. Let's see how I did. Woohoo! All right. So IV fluid bowls. This is like here's one thing I want to say. All of these are important and all of these we're going to get done, but we always want to think about that sometimes if you're in nursing school, professors can sometimes ask like, what order are you going to do these in? Now, I've heard a variety of opinions on which ones need to be done first. But in general, where we start is this, like, almost, I have seen very few people disagree that we always start with the fluid. Fluid is going to be the quick, most readily available, and it's definitely needed because they're usually very hypotensive, and they also really need that fluid return to them. Excuse me. And but then surprisingly, which you might find this surprising, you might not, one of the second things we usually do is antibiotics. And don't quote me on this because, again, all professors are different and they might say a different order. But antibiotics are also going to be high up there. So this might seem counterintuitive because most of the time we see, okay, we need antibiotics, but we don't see it as a priority. But in sepsis, it is. If we don't start getting ahead of that bacteria that's in the blood, it can become so overwhelming that no amount of all the other treatments we're doing are going to be helpful. So with these patients, we usually start by doing IV fluids, and we usually give a bolus based on their weight, or depending on your hospital policy. And we do that, and then we're going to give some antibiotics. We're going to give them some broad spectrum until we can get them something that's more specific to what they have. Get some labs probably, see what their white blood cell is, so we can start trending that. See if they're having any electrolyte imbalances. A lot of times patients with UTIs can have things off, but this patient probably, I don't have it on here. We probably also want to check a glucose. And see what's going on with their glucose, especially because they're diabetic. But in septic shock, the glucose can be significantly off and significantly elevated, even beyond what it would be normally for just a diabetic patient anyway. Lactate, this is an important one. If you don't know about lactate, learn a little bit. So pretty much lactate is, think of this as like the sign, like the woo, woo, like siren, that your body doesn't have enough oxygen. And that it's pretty much, think of it like the same, if you remember this with DKA, how you go into diabetic ketoacidosis because your body's like, I don't have enough sugar, I'm going to start breaking down ketones. Well, the same thing, when your body doesn't have enough oxygen, it starts using alternative methods to get oxygen, and a byproduct of that is lactate. And so really, I want to say most of the time I've heard, at least in real practice, that we like less than 2, but every textbook is different. So know that number, and understand that the higher it is, the more that your body is using alternative means for oxygen. So the more hungry or desperate it is for oxygen. We want to get an EKG just to make sure that her heart is stable, especially with her cardiac history. And if she's dehydrated or having other issues, she could have some electrolyte imbalances. And then, like I mentioned, you want to get those cultures. And so like the other labs and stuff like that, that's definitely important. But the first thing I need to do is start treating the problem. The one thing you want to consider is before you get those antibiotics, you do want to try to get a culture first, because if you don't get a culture before you get the antibiotics, you can skew it. So I know I said IV fluid bolus and then probably antibiotics, but IV fluid bolus, I should say culture and then antibiotics. Now in real life, all these things are getting done simultaneously. Someone's hanging the fluid, someone's getting the culture, someone's getting the antibiotics, etc. But if you had to put those in order, that's the one that makes sense to me. But again, don't quote me, don't hold me in a court of law, because all professors have different logic, and things also change. So let's talk about where our hemodynamics would be at. So what would we expect our hemodynamics? So I have 3 sets of hemodynamics here. This first one is CVP and PAWP. This should be what you're thinking about is fluid status. What's my fluid status? SVR. This is my vessel status. How are my blood vessels doing? And then CO, or cardiac output. How is my heart pump doing? So we want to think about what would we expect my heart, how is my heart doing? How are my vessels doing? And what would my fluid status be? So when it comes down to it, CVP and PAWP, this is a vasodilation shock, like I mentioned. So if I'm vasodilated and fluid is seeping out into my tissues, do you think I have a lot of fluid in my blood and going back to my heart, or not a lot of fluid? The answer should be not a lot of fluid. This should be low because I have low cardiac output as a result of this vasodilation. I'm sorry for all the coughing. I'm just dying inside. But yes, when you're looking at this, what you want to consider is that CVP and PAWP is all about fluid status. Now, a good general reminder is that in all types of shock, it's usually going to be low, except for in cardiogenic shock. Cardiogenic shock is the only one where this is high. And I mean, if you learn about obstructive shock too, it can be high in that one, but generally CVP, PAWP is always low, except for cardiogenic. So if you have a high CVP, PAWP, you haven't done any treatments yet, and you're just looking at hemodynamics, generally you're talking about cardiogenic. So then SVR. So SVR is a measure of how my vessels are doing. Are they open or are they closed? So if I have, hold on one second, my son's knocking at the door. See if he goes away. Let's see, yeah, I think he went away. So SVR, the squeeze vessel resistance, am I open or closed? One second, I think he's knocking still. At least I'm still up to my old tricks with the interruptions. It wouldn't quite be a video by me if there wasn't a lot of interruptions and weird, inappropriate things happening. And yeah, but I know it makes you miss me more, right? Anyway, SVR. So SVR, squeeze vessel resistance, it's how open or closed your blood vessels are. So am I vasoconstricted or am I vasodilated? So you're going to see for some people, for some types of shock, it's going to be increased. And really the only type of shock you're going to see, excuse my burps, see it increased in is going to be cardiogenic again. Now, sometimes with hypovolemic, it can be increased because the body's temporal. Oh, a second, I have to cough again. It's a really cute look. Luckily the video is almost done. I promise you won't have to listen to this forever. So SVR, like I said, it's usually only in cardiogenic, but sometimes in hypovolemic, it can be high as well because the body's compensating for the blood loss, so it vasoconstricts. But all the other types, neurogenic shock, anaphylactic shock, septic shock, we're all vasodilated. So this number is going to be low. Then cardiac output or contractility. So my cardiac output is going to be low because it's shock, so it's going to be low. But there's not actually a contractility issue here. And this is something that's really important to know. When you're looking at hemodynamics in a type of shock, you can't just look at the numbers and know what to do, because sometimes they're all contradicting each other. You have to think about, okay, not just, hey, this is like what I always tell students, write out, is it going up? Is it going down? Like what direction are we going? But then think about what's going on with the patient. So for this patient, I've got low CVP, low SVR, and low cardiac output. So everything looks low. The only things that are high are my temperature, I got my high respiratory rate, things like that. So what we want to look at that, but you want to think about why is that happening? It's happening because I've got bacteria that is causing me to vasodilate, and that there's this vasodilation, because there's inflammation going on. It's not the bacteria that's causing it, but it's the inflammatory process that's going on. And then I'm low on fluid because I'm vasodilated. So what do I need to fix that? So same, sorry for all the interruptions with that noise, but let's turn this around and act like this was a different patient. Let's say that we're looking at a heart failure patient. This is cardiogenic shock. Then the CVP would be up, the SVR would be up, and the cardiac output and contractility would be down. And so we have to think about what's the problem. Well, the problem is they have too much fluid, their vessels are really clamped down, and their heart can't pump. But even if I get rid of fluid, even if I unsqueeze their vessels, that's going to help their heart to pump a little bit better. But if there's a problem going on in the heart, we have to fix that. So same like septic shock, we have to fix the infection. Cardiogenic shock, we have to fix whatever is messing with my heart pump. Hypovolemic is super simple. Replace what's missing, but first stop the bleeding. So like, again, like it's the same, like if you look at hypovolemic, I can give a ton of fluids or give a ton of blood, but if they're still bleeding, it's just, like pouring into an endless ocean. That's never going to stop. And so you always want to look at your hemodynamics, but you can't just look at those and always know exactly what's going on. You have to look at the story too and see like, okay, what's the problem? Because the fix is going to be getting to the bottom of whatever the problem is. Hopefully that makes sense. I know it's tricky, but I promise that, or, it's hard to kind of get used to, but really try to always go to the bottom of what is the problem with this patient, like what is causing it. At the end of the day, like this patient, what's causing their problem is the bacteria. But we have to treat because they have such a low level of fluid. We got to treat that low level of fluid, get them antibiotics on board after we get that culture. And then we're going to start treating the numbers more, but we have to get to the bottom of the problem because again, I could do all these other treatments and it's not going to happen. Take a sip while, so I'll have to pause again. Luckily, this is the last slide. I love you all, but sometimes it's hard when you're sick to talk. All right, so what would be an expected result of the following treatments? And what would be a sign there's a problem or it's not working? All right, so if I give an IV fluid bolus to this patient, what would I hope happen? Well, I would hope that they're like, I don't want you guys to think like hemodynamics. I would hope their CVP would go up. I would hope their blood pressure would go up and therefore their MAP would go up. And, possibly their cardiac output could go up if that is increased. So we'll see. A sign of there being a problem or it's not working is I give it, but their blood pressure is still low. Their CVP is still low. Their MAP is still low. Or the other end, that there's a problem. Maybe I give them too much, and they start having difficulty breathing, or showing signs of fluid overload. So you always want to think about that. If there is too much of a good thing. There was a patient I was helping with the other day that we started she was showing signs of kind of being a little shocky. So we started giving her some fluids, and then we found out later she had heart failure. And so she did then her lungs started sounding kind of wet, and we were like, oh, but at the time with the information we had, we did the best that we could. So it does happen sometimes, but you always want to be looking for signs that it's effective. Norepinephrine. So this is something we haven't talked about yet. So generally with septic shock, we give fluids, and if people are not responsive to them, so let's say we gave fluids, maybe for a short period of time, or maybe not at all, they had a better blood pressure and improvement, and maybe their heart rate went down a little bit. But let's say it's still, their blood pressure is still low. Their MAP is still not 65. That's when we add pressors. I cannot stress this enough. You always have to do fluids first, fluids before pressors, because there's not like a caveat to that. If the tank is empty, we can't squeeze it. So you have to have fluids on board first before you can squeeze those vessels with norepinephrine. So with norepinephrine, the expected results, of course, would be increased blood pressure. It does increase heart rate, but that's not what we're trying to do with it. We're giving it to increase the blood pressure. So hopefully they would have increased blood pressure, and the increased MAP with that. A sign that it's not working is that we're going up and up and up, and their blood pressure is not increasing. And I will tell you just a little side tip, not for testing stuff, but for real life, is if you are giving this and you're not seeing any change, make sure you have a good line, make sure it's attached, make sure it's going in. And especially sometimes we use this in emergencies. It might be going through a peripheral IV at first. I mean, officially per your textbook, you're not supposed to do that, but real life things happen. You always want to check your line and make sure that it's a good IV and that you're not having any problems or your central line is verified, etc. Or sign of a problem, of course, is it can increase your heart rate significantly and cause some tachycardia. It can cause problems in the blood vessels. It's a vesicant. Things like that, because it's like a fight or flight hormone, so it can lead to some issues. The biggest thing we always talk about with norepinephrine is it focuses on getting blood here in the middle of your body. So sometimes if you're on it for high doses, long periods of time, you can lose fingers and toes because it gets so constricted in your peripheral circulation. So watch closely, minimum dose that you need to keep their MAP greater than 65. And then last but not least, ceftriaxone, that is an antibiotic, Rocephin. I would expect that they would start to, of course, have improvement. Now, I know it sounds crazy because you're not really giving the Rocephin to treat their shock state, but it can help to improve it because the body starts to heal from its inflammatory problems, and then it can start to go back to that normal oxygenation patterns and get what it needs. So, but you can start seeing improvements. It's not that this medication is going to improve directly your hemodynamics, but it helps on the side that when you fix the problem, then the body can go back to what it was doing before and hopefully heal. So of course, hopefully the more direct things you would look at is like a negative culture. or decreased temperature, maybe start feeling better, mental status improving. A lot of times, like I mentioned, older people, they get kind of cuckoo for Cocoa Puffs when they have an infection. So a lot of times you'll see their mental status clearing. And then, of course, sign of a problem, they can have allergic reactions. It could do nothing. They could still have the infection. Maybe it's not the right antibiotics. That's why we have to get that culture and sensitivity, make sure we're using the right ones. And then check like serial temperature check, stuff like that. Sometimes people can get secondary infections and things like that can happen. So what are the desired outcomes or goals for this patient? So as a whole, of course, if I was making a goal for this patient, it would probably be something along the lines of wanting them to keep a MAP greater than 65, wanting them to show signs of improved mental status, remain free from fever, have a decreased lactate, things like that, be more arousable, higher level of consciousness, whatever it might be. And so it would be signs of like that they're having better perfusion. So we can look at their blood pressure, we can look at their mental status, things like that. And I always try to do the most direct measure, and I always try to do it specific to that patient. But yes, we want that to be better. One other thing I didn't mention is, a treatment that will probably be included in this is oxygen. It's kind of more of a general than specific to septic. And we're going to use it if we need it. We do like their oxygen levels to be a little bit higher with shock because it's like a supply demand issue. And so we're trying to give them more of a supply since there's going to be more of a demand while they're going through all this. Aside from this, I might also need some insulin or treatment for her hyperglycemia, which she most likely has, and keeping a close eye on how she's doing with her sugars to make sure she doesn't go. A lot of times people end up in DKA when they're dehydrated with an infection. So want to keep a close eye on that. But yeah, that's pretty much it for this case study. Hopefully walking through this gave you a little insight, or maybe it's all the same stuff. And but either way, thanks for spending these 30 minutes with me. Hope you had fun. See you for the next one.